Thanks for the introduction. Martha and I are going to tag team this presentation, so it's one kind of uniform presentation, just divided up into a couple different modules. There we go. A couple of disclosures you can look at. So we're going to be talking about liver, pancreas, and prostate SBRT in this section. We're going to divide it up into kind of this outline for each of the different sites. First, I'll go into clinical evidence and patient selection for each site, patient positioning and simulation, delineation of targets in normal tissues, margin considerations, image registration, and then target and normal tissue doses. And then I'll hand it over to Martha, who will talk about planning techniques, trade-off priorities, and IGRT, and all the technical considerations of planning. So a little bit of background on liver tumors, because it's not that common for patients to be treated with SBRT for this still worldwide. There are basically two flavors of liver tumors. There's primary liver tumors and metastases that start in another part of the body and move on to the liver. In both cases, there can be long-term survival if the patients can have surgery, but many patients can't have surgery. And for patients who can't have surgery due to tumors which are too big, too many, or in a bad place, or patients who have a poor functional status, we need to have a treatment for these patients that's beyond just chemotherapy, which isn't that effective. So what are the options for patients who can't have surgery that can be very ablative treatments? Well, there are the local options of radiofrequency ablation, which is basically putting either 1 or 3 needles into a liver tumor and burning it to death. That's limited by tumor size and location, so if it's next to bowel, you don't want to burn the bowel. If it's next to a blood vessel, you can't actually heat it enough to burn the tumor to death, so those areas in particular can't be burned. And tumors near the diaphragm can't be visualized to be burned with RF ablation. And then there's radiotherapy, so those are basically the two local options beyond surgery. And then we have kind of a tiered approach to treatment of liver tumors. So if there are too many liver tumors to treat with local therapy, then we move on to regional therapy, which would be an injection of a region of the liver with either chemotherapy beads or radiation beads. And then if somebody has failed beyond the liver, then there's a consideration for systemic therapy, chemotherapy or smart drugs to take care of cancer everywhere. So historically, radiation has been very tricky when it's been given to the liver because there's a risk for radiation-induced liver disease. And that, as many of you know, is a constellation of ascites, hepatomegaly, and increased liver enzymes. It happens a couple months after radiation. There really isn't much that can be done for it besides supportive care. There are some drugs that are available for Italy, but they're always on strike. So whenever you need them, they're on strike. It can also be fatal. We know, on the flip side, that radiation can be very helpful. And from the 3D days of fractionated radiation, we know that high doses can actually control tumors locally and also potentially could give a tail of long-term survivors. And so really with the advent of SBRT, we've been able to popularize liver radiation to an extent that really wasn't possible in the 3D era. And the rationale for SBRT is very relevant to liver tumors. The high doses per fraction might have a biological advantage. Dose fall-off is very rapid, so you can get a high therapeutic index. And practical considerations, like in patients with a poor prognosis, we want to minimize the duration of therapy. When I first came to the University of Michigan, 12 years ago, we used to hospitalize patients for BID radiation for 7 weeks with hepatic arterial chemo infusion. And now SBRT is far more effective, far more convenient for patients. And of course, treatment is more convenient, more efficient with SBRT. Instead of weeks and weeks of therapy taking up time slots on the machine, it can be done in just a few different days. So what do we know about the evidence for SBRT for intrahepatic malignancies? Well, there are a lot of retrospective reports, and there's still very few prospective trials, and that's kind of the state of clinical trials in the United States. We keep trying to push clinical trials, but it is difficult. Most of the patients in the reported literature have liver metastases because those are patients where their livers are much more forgiving. It's easier to treat patients with liver metastases. Patients who have primary liver cancer have cirrhosis and their livers are very fragile, and it could be very tricky and potentially dangerous to treat them. There are very few comparative studies as well, so we really don't know how SBRT compares, for example, to regional therapies like injected beads or burning procedures, or until now. So SBRT for liver metastases is really easy, as I said, generally speaking. A normal liver has very high regenerative capacity, so somebody can have 2/3 of their liver cut out, and the rest of the third actually hypertrophies and grows up and becomes a normal-sized liver again. And so we can do a lot to these patients' livers, and SBRT in a normal tumor is generally quite safe. That is, until you start getting into very large tumors or multiple tumors over time. And with SBRT, in-field local control is at least 90% for 100 BED. First SAM question. In-field local control for SBRT of the liver with at least 100 BED is expected to be? The accuracy should be at least 90%. Oh, okay, great. It's after lunch. Okay. So SBRT for HCC is a little trickier, as I said. The cirrhotic liver has very limited regenerative capability. Very little of the liver can be surgically removed before putting a patient at real risk for mortality after surgery. And so SBRT is very, very challenging, and we really have to balance local control and toxicity. The additional consideration for HCC is that patients have what's called field cancerization effect. They usually develop a hepatocellular carcinoma in the setting of cirrhosis, which makes them develop new tumors in other parts of their liver. So in addition to controlling the liver tumor we know that we see on scan, we have to think about the next tumor the patient might develop in 6 months, 2 years, or 3 years, and the next one after that. And so kind of reserving some liver function for the future is a very important concern, because these patients won't just regrow new liver like liver metastases patients. In-field local control can also be 90%. So here's just a smattering of different series that are published for HCC, and you can see that local control is variable, but in the more recent series, it's getting up into 90% range. The total doses and dose per fractions have been variable over time as well. And then you can see toxicities here. I mean, radiation-induced liver disease is real, and it still happens even with SBRT. Excuse me. Thus, it needs to be done very, very carefully. So I had mentioned before that there are a couple of different ways to ablate a liver tumor, to kill it off once and for all. SBRT is one of them, surgery is another, and then radiofrequency ablation is another one. And until now, there really hasn't been any data or studies comparing the effectiveness of SBRT and RFA. And one of our great residents just got a paper accepted to change that. I think it'll change the field, really. This is a retrospective review of 161 patients with HCC, and they were treated with RFA, and then 63 patients with SBRT. So there were about 300 liver tumors. Overall, the liver tumors were about the same size. You can see local control between SBRT and RFA. SBRT actually is slightly better for all patients, and local control is better for SBRT. If you look at size, for RFA, size really matters. But for SBRT, size doesn't actually matter. No matter how big it is, local control is still very good. So for tumors less than 2 centimeters, SBRT and RFA have approximately equivalent crisscrossing local control. But for patients that have tumors that are greater than 2 centimeters, the local control for SBRT stays and plateaus up here, and RFA keeps going down and down and down. So I think this will really change the field, hopefully. At least in our tumor board, it's already changed so that patients who have tumors greater than 2 centimeters are usually sent over for SBRT rather than RFA. And this is just another illustration that as the tumor size gets bigger and bigger, the advantage of SBRT actually gets larger and larger. So what about toxicity? And this is really the main reason to consider SBRT over RFA, and if there are any physicians in the audience, this is what you talk about in tumor board. As you know, SBRT is completely non-invasive. It's very easy. Patients work during treatment. I tell patients that the main side effects are inconvenience and boredom, truly. But RFA is an invasive procedure. Patients undergo general anesthesia, so there are anesthesia risks. They have 1 to 3 needles placed in the liver, and a lot of these patients have platelets that are very, very low, so there's a bleeding risk. And then anytime you put in a needle, there's any sorts of complications that can happen, and they're rare. But if you're one of those patients that has that rare complication, it's really terrible. So for RFA, for all these patients, there was a pneumothorax, so somebody's lung got perforated and dropped, infection, perforation of the duodenum, perforation of the colon, bleeding, and 2 people died within 30 days. For SBRT, there was 1 case of radiation-induced liver disease and a patient who had had multiple treatments beforehand and was a child Pugh B patient, 1 case of GI bleed, and 1 case of worsening ascites. So any treatment has risks. We have to make sure patients understand that any treatment they're going to have is associated with risks, but we do need to present patients with a realistic picture of what could happen with either treatment. So how do you select patients for SBRT then? The classic patients would be patients who have either a normal liver or what's called child A liver dysfunction, so mildly declined liver function. Tumors up to 3 centimeters because you get the best dosimetric fall off from that. Pushing the envelope though, we can treat patients with multiple or very large metastases as long as it's done very carefully. Patients with multiple or large HCC tumors and cirrhosis. But I would recommend treating at least the HCC patients on clinical trials like the RTOG 1112 that I hope you have open at your institutions. Here's an example of an IMRT case, SBRT case, essentially pushing the envelope. This was planned with VMAT, and you can see this giant tumor involving, I don't know, half the liver, including the portal vein, going all the way down to the bowel area. And this patient had a tumor marker of 93,000, and then immediately 3 months after SBRT, his AFP went down to 5, and it's still there 2 years later. So how do we actually set patients up from the beginning for liver SBRT? Well, this kind of depends on whether it's a metastasis or a primary hepatocellular carcinoma. For both of them, you need a CT simulation. Generally, we do it with supine, arms up, body immobilization, IV contrast. It's very important to get the timing of contrast right for the abdomen, whether it's liver contrast or pancreas contrast. The timing is very, very important. So for metastases, a delayed 80-second scan is very useful. And then motion assessment and management is very important as well. For hepatocellular carcinoma, most of them are very difficult to see even with a contrast-enhanced CT scan, so MRI is very, very important for that. And we need to get both the arterial and the portal venous phases because some tumors are better visualized on the early and some are better visualized on the delayed. And we get this at, we happen to have the luxury of having an MR simulator, so we get this done in exhale breath hold. That means that our CT simulation and our MR simulation are at the same breath hold state. Before we had an MR simulator, we would have to negotiate with radiology to make sure they got an exhale breath hold MRI to make sure the liver was actually the same size and same configuration for registration later. And it can be done, it just takes more communication with radiology. So we like to template everything. I like to template everything. So basically you can make things run on autopilot that are simple and spend time on more complex parts of the entire workflow. And so this is an example of a liver simulation directive. We have motion management instructions up here, immobilization, which will then later impact PTV, so it's important to think about that ahead of time. The motion assessment part down here, which will impact whether you have an ITV or not. And then the IV contrast is important to tell your sim therapist what time, what do you want to scan at 40 seconds, 65 seconds, 80 seconds, because that will really impact how well you visualize the tumor. So all that information would be really nice to have up front so there isn't any miscommunication at the time of sim. So how do you contour these targets in normal tissues? For metastases, it's relatively easy. Just use the portal venous phase of the contrast-enhanced CT, and here's an example here. For the portal venous phase, basically the liver lights up white, and the tumor is dark. So you just look for a hole like Swiss cheese. And here's a dark hole here. I don't know how well it projects up there. Dark hole in the white liver. For HCC, sometimes they're better visualized on arterial enhanced phase imaging, which will show the tumor up as white here amongst a darker liver background, versus some other tumors that show up better in the portal venous imaging, where similar to the CT scan, the liver is white and the tumor is dark. So the way that the tumor looks really depends on exactly when the scan was obtained. In addition to contouring the tumors, of course, we need to think about the OARs, and in the abdomen area, stomach, duodenum, small bowel, colon, heart as well, because a lot of our tumors that we get are right at the diaphragm. That's why they couldn't be burned with RFA, and the ones that are at the diaphragm are right next to the heart, and then chest wall as well, so we don't cause any rib fractures. So now we have the tumors contoured, and what about margins? We typically use GTV equals CTV, and any additional margins really depend on any of the upstream decisions that you've already made, and ideally have already written down in a standard fashion in the simulation directive. So immobilization impacts PTV margin, motion management impacts whether you have an ITV, and then all these other things also impact the IGRT that you're going to use later. So image registration. Image registration for liver tumors can be a little tricky, and that's why it's especially important for liver to have a very well-defined workflow that's very consistent, especially if you have multiple people handling that along the different steps along the path. It's very tricky for many reasons. One is that there's deformation of the liver, less so if you get an exhale and an exhale scan, MR and CT to register, but more so if you have a exhale to inhale scan that you're trying to mash together one liver geometry to another liver geometry. Another complexity is that it's very difficult to see HCC on CT, so it's not that easy to check your registration to make sure it's correct, so you have to rely on surrogates nearby. And then there's also complexity of managing multiple data sets and coordinate systems with not only the CT and the MR, but if patients can't hold their breath, then a 4D CT or slow CT or whatever you have in order to manage the motion, and just making sure that the 000 matches up in all of those places in the correct way. So in order to make this easier, because there are multiple people involved in this, we have set up a registration instruction sheet. Actually, Christy Brock, who's going to be talking later, set this up for us, which is genius, I think. So what it does is it allows physicians to communicate to dosimetrists or physicists or whoever's going to be doing the registration where that tumor is that you care about. Because in the liver, you're not going to be able to register the entire liver contour with the entire liver contour. You're going to have to bias the registration to just where that tumor is. And if the person doing the registration doesn't know where the tumor is, you're not going to get the correct registration, and that could be a disaster. And so on this, we have a place where we can paste in the picture where the tumor is, so the person doing the registration knows exactly where to bias the registration to. And then we also have just a general description of where it is, so there's a backup just in case it's not clear. So here's an example. So if the GTV is down here at the very bottom of the liver and there are no instructions given, well, it's really easy to align it to the dome. And so if somebody doing the alignment doesn't know where the tumor is, they might actually align to the dome, and your GTV is clearly not anywhere near where the tumor actually is. But if you actually give them instructions to where to align, then you actually have a much better registration. In the future, once we have better deformable registration tools, this will not be necessary, but right now they're just not perfect. So what about target and normal tissue doses? So again, these templates are really useful for us. So up here we have the different GTVs, ITVs if relevant, and PTVs, and these all impact the margins that are going to be used for expansions. Down here we have predetermined trade-offs with priorities listed for different normal tissues down here relative to PTV coverage. So for example, if you want PTV coverage above anything else, you would put a priority 1 up here, and a lower priority for all the normal tissues, but I prefer not to overdose normal tissues, so I put priority 1 down here, and priority 2 is a tumor. So oftentimes the tumor, part of the tumor will be underdosed in order to save priority 1 structures. It doesn't matter necessarily how you come up with your priorities, as long as they're written down, so different people aren't just guessing what should be done for each particular case, and so that they're very, very standardized. Over here, we have a section on IGRT guidance. So any different scenario, there's instructions for it, so that at the machine, the therapists know how you'd like to have the guidance. Whether it's to fiducials, whether it's to avoid a particular normal tissue, it's really important to communicate that. Otherwise, there, again, will be guessing, and that's not going to be consistent or necessarily safe. So the different scenarios might be no markers breath hold, markers breath hold, markers breath hold, no markers free breathing, markers free breathing. All of these situations have well thought out scenarios all written down, so you don't have to reinvent the wheel every single time. And it does definitely take time up front to meet with your entire team from the beginning to end, so everybody understands why these decisions are being made, but it's very, very useful to put in the time up in the beginning to ensure safety and efficiency. So I'm going to move on to pancreatic cancer next, and then after kind of an abdomen session, I'll turn it over to Martha to talk about abdominal considerations for planning. So for pancreatic cancer, why even consider SBRT? It's much less commonly used than for liver cancer, but the rationale would be that it's more convenient, it's less costly, and allows for earlier systemic therapy. Radiation therapy for pancreatic cancer is slowly kind of being forced out because chemotherapy is getting better and better. On the other hand, many of us believe that since chemotherapy is getting better and better, that's why radiation is so much more important. So the systemic therapy will take care of metastases everywhere, but it doesn't really address the local disease as well as radiation. And so radiation now is starting to have a little bit of an resurgence. So what are the drawbacks of using SBRT for pancreatic cancer, though? The main thing that people are really afraid of, including me, is concern for late complications, including bleeding. And of course, you're physicists, so you know alpha-beta differences. For the same tumor dose, the normal tissue perceives a much higher dose, so you either have to take that accelerated risk or you drop the tumor dose. But how well does pancreas SBRT work? Oops, sorry. Now there's actually a combined experience of about 1,000 patients at least treated with SBRT. It seems to be relatively safe. There are, of course, pretty high percentages of acute toxicity. Some of these series have 0, some of them have 41. I would say in the fractionated therapy series, it's around 25 or 30, so it's normal to have side effects during radiation. It's the late toxicities that we worry about. And in these series, the original ones, there's very high late toxicities when people are trying to figure out what doses to use. And then as the series get more and more contemporary, the toxicity seems to be going down. So this is a study that was done by Joe Herman at Hopkins, and it involves Stanford and Memorial Sloan Kettering as well. And basically it's a phase 2 study for unresectable pancreatic cancer that started off with chemotherapy and ended with chemotherapy, but sandwiched in between there was 5-fraction SBRT with the rationale that the chemotherapy will take care of any micrometastatic disease, small mets throughout the bloodstream that you can't see on imaging yet, but that the SBRT was still necessary for local control so that the pancreas tumor didn't grow and eat into the nerves or eat into the duodenum and cause excruciating pain or bleeding. The primary endpoint was late GI toxicity because that has been the primary concern for pancreas SBRT, and then they wanted to see how well it worked also in secondary. So they had 49 patients, and they had 11% late grade 2 toxicity, which is quite good for SBRT and very promising. So overall, the median survival was 14 months, which is about on par with any fractionated radiation series, so not better, but not worse, and condensed into 5 days. Overall survival curves you can see here, and progression-free survival as well. Overall, with the doses they use, there was about a 25% local progression, which is about on par with fractionated series as well. So who should be or could be treated with SBRT for pancreas cancer? Well, right now, I would suggest confining it only to the unresectable and borderline resectable patients, if any at all. There are some trials that are starting up with resected patients, so post-surgery, looking at tumor bed radiation, but I wouldn't do that off trial because that definitely has much less literature, if any. In the multi-institutional study led by Joe Herman, they had a size limit of 7.5 centimeters. The most important thing is no invasion of the stomach or bowel, because if you treat the stomach or bowel with SBRT on purpose, you are going to have complications. And then the last caveat is really preferably to be treated on a clinical trial. So what about patient positioning and simulation? Generally, supine arms up, body mobilization, IV contrast, and we'll go over the timing of contrast in the next slides, and then motion assessment and management as well. So here's the simulation directive that we use. Up here, under patient immobilization, these are the margins that you're going to think about. So PTV margin. Down here, motion assessment strategy is going to impact how much of an ITV, if any, that you have there. And then the IV contrast is really important. You can't see pancreas tumors without contrast. And we've settled on a timing that allows us to see our tumors very well at a 65-second delay. But if it's too early or too late, you're just not going to see it very well, and then you'll be upper peak. So this is important for GTV definition. And then how do we contour targets in normal tissues? Well, the only target that we contour is the GTV. It's controversial whether you treat nodes nearby, and there's basically two philosophies: to either give low-dose chemotherapy and treat not only the pancreas tumor but also the regional nodes, or the other camp that treats with high-dose chemotherapy and only treats the actual pancreas tumor. We're in that latter camp, so we only delineate the actual tumor that you can see on the scan. And then all the normal tissues around it, obviously, with duodenum, stomach, small bowel, kidneys. The other thing to think about contouring is also alignment structures. If you have fiducials placed in the tumor, you want to contour those to make sure people know that that's how they're supposed to align on the machine. If you don't have fiducials in, then you want some surrogate anatomy that's nearby to allow patients, allow the therapist to actually line up on cone beam, because you really can't see the tumor in the pancreas very well. So the surrogate anatomy that we typically use is the celiac axis and the SMA, which are basically these trunks coming off of the aorta that we've trained our therapists to look for. So margins for SBRT. In the multi-institutional study, Joe Herman and his collaborators used a GTV plus 2 or 3 millimeters. I'd say it's really a work in progress and should usually be done in a clinical trial again. Any additional margins really depend, just like in the liver, on any of the upstream decisions that you made about immobilization and motion management. And I did want to spend a little bit of time on image registration, because a lot of people don't think about image registration for pancreas cancer. So why would it even be necessary for pancreas cancer? I didn't think it actually was until recently. So many clinics I found out can't administer IV contrast for simulation. Apparently you have to, there are medical legal reasons about having plastics available for contrast extravasation and whatnot. So many clinics can't administer IV contrast, which means that they need to have a breath hold scan done in radiology with IV contrast to be registered to a non-contrast breath hold scan done in radiation oncology, and we'll go over how that will work. Some patients are treated free breathing, and we need a breath hold contrast scan, though, in order to see the tumor. So then many patients have a registration of a 4D-CT to a breath hold exhale contrast enhanced scan. And then some clinics are using PET to help with tumor delineation as well, so fusing that data set with a breath hold contrast enhanced scan is challenging. So what about the scenario where IV contrast can't be administered? So you have a diagnostic radiology scan in end inhale position, and you have a CT simulation scan in end exhale position. So how would you guide the registration? Do you do spine alignment? Do you do soft tissue alignment? So here is an example of what would happen in the scenarios. So here's a pancreas tumor here in red. Here's the duodenum in blue on the simulation scan. So what if you just fused it directly with bony alignment to your diagnostic scan? Well, your pancreas tumor is now right in the middle of your duodenum. And so instead of radiating the pancreas tumor up here, you're now radiating the duodenum instead and not treating the pancreas tumor. And this is very easy to do because the alignment is not intuitive necessarily, and you can't really see the pancreas tumor without contrast as a kind of logical double check that you're doing something right. So it's very important not to do this. So what about target and normal tissue doses? You're going to hear me say again and again that it's a work in progress for pancreas cancer, and it is. But in the multi-institutional study that was recently published in Cancer, this is what they used. They had limits for the proximal duodenum, stomach, and small bowel. They had limits for the liver, kidneys, and spinal cord. And the PTV dose they used was 33 gray and 5 fractions. Again, under construction. So the NCCN guidelines you guys might have heard of before, it's a panel of different comprehensive cancer centers, and there are different surgeons, radiation oncologists, medical oncologists, gastroenterologists, now a radiology panel, and pathologists for all different disease sites. And for the pancreas guidelines for last year, this is what we have for SBRT. No standard total dose or dose per fraction has been established for SBRT, therefore it should be preferably utilized as part of a clinical trial. That language will still be there in the 2016 version, which we're working on right now. It's very promising. It looks like overall survival is very similar to fractionated treatment. It looks like local control is very similar, but it needs to be done in a very, very careful way. And the reason that we don't have more specifics in the guidelines is the feeling that if you need to read how to do it in the NCCN guidelines, you shouldn't be doing it. You should be coming to a session like this and learning a little bit more about it, going to visit Joe Herman or going to visit Stanford or wherever they're doing a lot of it, and really learn how to do it in a very careful way, because otherwise it could be very dangerous. So what do we know about late toxicity and dose beyond what's in one or two or a couple of retrospective reviews of small series? Well, Thomas Brunner and his colleagues put together basically a model of GI toxicity. So this is toxicity rate of greater than grade 3, looking at both EQD2 and the LQL model of BED. And you can see that this curve for toxicity really starts to take off at some point for EQD2, and it's not quite as steep for BED just based on the modeling. And based on that, the paper recommends a 75 BED limit to be adhered to. And they tabulated different retrospective reviews and some prospective studies of pancreas SBRT, and they basically converted to EQD2 with an alpha beta of 3. And if you look at this, you see that the duodenum got a very high dose if you convert it to EQD2. I think mostly in the early days when people weren't really paying attention to the EQD2 and alpha beta 3 corrections, because nobody would do this anymore. But this at least gave us some data of the higher doses in order to model. So, Sam's question. A safe and effective BED for pancreas SBRT likely is 150, 100, 75, 50, or 25. Awesome. 75. Okay, I'm going to turn it over to Martha to talk about the physics aspects of abdominal SBRT.
Thank you, Mary. So we're going to have a talk later on today about motion management in general by Carrie Glidehurst, but I know she's going to focus a little bit more on lung, and since motion management is so important for abdominal SBRT, both in liver and in pancreas, I wanted to cover that in this talk as well, is talk about planning and IGRT. Let's see. Okay. So we know that there's a lot of motion in the abdomen. So we can look at APMTG 76, where they've kind of summarized some of the literature on motion magnitude, and we're seeing magnitude up to 3 to 4 centimeters even at shallow breathing in the abdomen. So we know that this is a really important issue and has to be considered for abdominal SBRT. And here's another example of a paper where they looked at marker motion within the liver, and they've kind of placed the magnitudes and excursions here in the different planes, and you can really see that although the majority of the motion is superior inferior, there's a lot of motion ante-post and in other directions as well. So this is a really important issue to think about for any time we're treating in the abdomen. And we know that it's essential for outcomes as well. So this is a paper that was published where they used a free breathing simulation, and they compared their outcomes in local control for kind of more static tumors with SBRT. So these this blue curve is for lymph nodes, and red is liver and lung, and then green is other. And so they didn't apply any motion management and applied PTV margins of on the order of 1 centimeter, thinking that that would be enough to account for motion. And they really saw a big percentage of infield and marginal failures in the liver and lung group compared to the more static lesions. So we know that this is really important to take into consideration. And we know that it's not just something to look at simulation. We see that patients' breathing patterns change throughout treatment and even throughout the same treatment session. And so the different techniques that we can use to manage and assess motion in the abdomen are very similar as what you would see for other sites where we worry about respiration. So motion encompassing methods, so the ITV approach, motion elimination methods, which I kind of put in quotes here because it's very difficult to completely eliminate motion. So breath hold techniques, motion dampening such as compression, and motion gating, and then motion synchronized treatment such as tracking. And so if we look at the ITV approach, this I think is by far one of the most common methods used to manage motion, is that we want to capture the extent of the motion during treatment so that we can capture that for treatment planning. And one of the things that I've liked to do more recently is instead of calling this an ITV, kind of use IGTV or ICTV. So ICRU recommendations, of course, would be that the ITV is the motion encompassed CTV, but I think in many places, especially looking at SBRT, where we may not have a CTV, the motion encompassed GTV is what many of us refer to now as the ITV. So in many new NRG trials or RTOG trials, we're kind of switching over to IGTV and ICTV to make it a little more clear. And so you can do an ITV approach by taking a 4D CT. So this is clearly a slow scan, bend into amplitude or phase-sorted scans from a breathing phase indicator at your simulator. You could do an inhale or exhale scan pair, or you could also do a slow CT, although this is not recommended for abdomen because there aren't the same contrast differences that you'll see in the lung. And so this is just an example of one of our patients where we are going to treat the patient free breathing. So here on the left we have the GTV drawn on a voluntary exhale contrast CT. This was taken based upon a nice simulation directive put together by Mary. And then over here you can see the 4D CT. So here we can see the excursion of the tumor on 4D. This is one of the probably rare liver tumors where you can see the tumor on the 4D CT. And you'll be able to appreciate that our ITV is obviously going to be a little bit bigger than our GTV, so potentially increasing the risk for treating additional normal tissue as your motion magnitude gets bigger and bigger. Inhale-exhale scans, as I mentioned, if you don't have a 40 CT, you could employ this approach for motion management. Otherwise, I think 40 CT is really the gold standard for measuring motion for a free-breathing patient. Keep in mind that inhale-exhale scans done under coaching can be somewhat inconsistent. If you just try yourself to hold at a normal inhale or a normal exhale without exaggerating the breath hold, you can do it very differently each time. And so if you have a breath hold device to aid in this, if you don't have 40 CT, that would be something good to look into. And then there's also abdominal compression. So this isn't something we do at our clinic, but I know many clinics that employ abdominal compression and swear by it. This is just an example from a paper where they looked at 10 patients, 6 liver tumors and 4 lower lobe lung tumors, and they measured motion on 40 CT with and without abdominal compression at different settings. And so you can see most of the motion they're going to see is in the sup and inf direction. But if you look at the overall motion without abdominal compression, they kind of saw an average motion of around 1.5 centimeters. But with compression, either medium or high, you can reduce that down, to 5 millimeters, 1 centimeter in that range. And at least in our clinic, that 0.5 to 1 cm range is really when we think it's most important to apply a breath hold technique or motion management technique during treatment to reduce the amount of normal tissue that we're treating. So compression can certainly be used to help bring the patient's breathing back down into a manageable level. And this is just another example where they looked at pancreas. And so here, pancreas, we don't see quite as much motion, but as Mary mentioned, it's very difficult to see the anatomy around the pancreas. And so a free breathing scan used for IGRT that we don't have markers in can really be obscured by motion, even just 5 millimeters of breathing. So pancreas motion we can dampen by about 3 millimeters, which is certainly helpful, especially with IGRT and with planning, because with pancreas you have the tumor surrounded by all of the abdominal OARs, which have very low limits compared to the doses that you're trying to go to with SBRT. And just another example here, 12 patients with implanted gold markers looking at fluoro with compression here in the free breathing excursion up to 2.5 centimeters, and then here with increasing compression, getting close to the 5 millimeter range. And so I think with proper use and training, using compression is pretty simple and can be well tolerated by patients, but it does require experience with your clinic. So it's not something you want to do on random patient here or there. You really want to make sure your whole treatment team has experience with this technique. And then there's gating. So the goal of gating is really to minimize the amount of normal tissue being treated by only treating the patient when they're within the gate window. So of course we know that this increases treatment time because it reduces the amount of time that you're actually treating the patient when they're on the table. It also allows you to treat more patients with this technique than, say, breath hold. So in our clinic, we certainly prefer to use a breath hold technique over free breathing, but not every liver or lung patient can actually hold their breath with or without a device. And so gating is a great option for those patients that have trouble with compliance or other issues because it's kind of passive on their part. You do need to be very careful to validate any tumor motion surrogates. Usually gating is based on an external surrogate, although there are many gating techniques that can be based on internal surrogates such as markers. And it's very important at your own clinic to validate whatever your surrogate is or any lag time that you may have in your system. And so you do need to employ a lot of QA, and you'll have to have special equipment such as a motion phantom to really well commission any gating technique. And so this just shows that for 20 liver SBRT patients that were gated, just a huge variation in the gating window that can be used from fraction to fraction. So it's not a matter of setting up the gate at the time of simulation. We know that patients' breathing patterns change, and even correlation between your internal and external surrogates and tumor motion can change as we go through the treatment course. And so it's something that has to be looked at each fraction, not just at simulation. Now, what about tracking? So tracking is a great way also to reduce the amount of normal tissue that you're treating. You're tracking the tumor instead of comparing it to, say, an ITV technique where you're treating the whole extent of the tumor motion. And so this is just an example here of target definition with an ITV approach with tracking, where you may see slight changes in hysteresis. So your tracking ITV is slightly larger than, say, your GTV that you would draw on a contrast scan or an MR, but compared to the full extent of motion with a full ITV, it's potentially a really large reduction in normal tissue dose and in volume of the PTV that you're treating. So this was a planning study and also a treatment study where they looked at 12 patients planned with motion in a motion encompassing ITV approach versus tumor tracking with an implanted fiducial. Both cases they used 5 millimeter PTV margins, and you can see the difference here in the treatment planning techniques. Here on the left is the tracking approach, and over on the right is the ITV or free breathing approach. And here you can really see the difference in the size of the area that you're treating, and also when you have a normal tissue adjacent to the tumor location, you can really change your dose gradients into that area and reduce potentially the normal tissue toxicity risk. And so they looked at the changes in PTV size and liver dose in this study, and what they saw is about a 35% reduction in PTV size using the tracking technique. So median tumor size 74 to 48 cc, and also a 16% reduction in the mean dose to the liver, which we know can correlate very well with radiation-induced liver disease and toxicity. Tracking, of course, requires proper QA and monitoring to ensure performance. This is just an example of their workflow here. So KV X-ray images updated every second, monitoring the edges of their marker to make sure they're within tolerance, and then also monitoring the patient's respiratory signal. And so I just wanted to say a little bit about registration. So Christy Brock is going to talk about deformable registration in her talk, and this is just an example of what we do in our clinic. So we have our contrast CT or MR, which is typically what Mary will use to contour her tumor on, and we will register that to the exhale phase of 4D CT. So with liver, especially with free breathing treatment, we end up with a lot of different scans. So making sure that you're registering, as Mary said, the right area of the tumor, but also the right scan to the right scan. So for those of you who may have this treatment planning system, you'll see the 4D CT, all of the individual scans come up together, and you need to select the one that you want to register to and display. And so you want to make sure if you have a contrast scan at exhale, you're not registering that to, say, the untagged or the average phase of the 4D CT, but that you're registering to the proper phase. And so this is just an example of this tumor registered to the 50% phase with our exhale contrast CT where we've drawn the tumor. And then we would create the ITV or the IGTV. So if we have a free breathing patient, we may be able to see the tumor on 4D CT. I've mentioned that this is uncommon. This was a really good example case. And so the physician could draw the IGTV directly using the phases, but usually that's not possible, and we're only getting a tumor on the MR or contrast CT. And in that case, we'll have the physician contour the GTV, register the proper phase, and then we'll create the IGTV by watching the motion of the tumor on the 4D CT. This can cause some problem if you're just doing, say, a certain expansion, sup and inf, and another expansion, ant to post. You may miss some hysteresis, so it's really important, given the tools that we have in our planning systems to create ITVs, that you watch the 4DCT movie, make sure that your ITV is really well encompassed within the margin that you've created. One thing that I want to mention, which I think is really important, especially for abdominal tumors, which may not have the same effect in lung, is to be aware of using your average scan from 4DCT for contouring, making DVHs, metrics. So many of us plan on the average scan, which is great because we can see the blurred diaphragm, we can use it for IGRT, but you have to be very careful about using it for normal tissue contouring. So this is just an example with the windows opened up of the exhale phase versus the average scan. So you'll see that the liver actually looks quite a lot bigger on the average scan that we see here in the green compared to the exhale phase, which you would expect because you're kind of opening up the window and you're getting the whole extent of the motion. But when you go to contour that liver, if you use the same liver windows that you normally would, what you'll end up seeing is that your liver volume on your average scan will actually be less than what it will be on, say, your exhale phase of the scan, just because you're getting that blurred density and the average CT number is going to be less. And so if you're calculating a mean liver dose or using it for one of your IGRT objectives or your planning objectives, you just have to be a little bit more careful. One thing to mention too is training and experience and resources are really essential for a motion management program. You need proper training of the whole treatment team, documentation, and workflow analysis to make sure you're using all of your tools in an efficient way. And making sure you have the right personnel, hardware, and software to do these abdominal treatments in a safe way with motion management. And so this is just an example of our workflow for simulation. This is something that Christy Brock put together. And so what we do for our breath hold simulation is we'll acquire 3 scans to look at the reproducibility of a breath hold. And if a patient isn't able to have a reproducible breath hold for treatment planning, we may decide to treat them free breathing, or we may decide to employ some additional breathing instructions for that patient. And then, of course, we do a very similar process on the first day of treatment. So treatment planning priorities for abdominal SBRT are a little bit different than maybe some other sites because we have very strict normal tissue objectives for the abdominal OARs. So the first priority is always to meet what we would call non-negotiable normal tissue objectives. So core, duodenum, stomach, etc. There are many important abdominal OARs that we cannot exceed their limits without severe risk of toxicity. And then our second priority is typically to satisfy dose compactness criteria with an SBRT-like dose distribution to the target, review your conformity and gradient indices that were talked about in the last presentation, and also then to meet your lower priority normal tissue objectives, and then just to minimize overall dose to the normal tissue and to minimize your plan complexity. One thing that we employ in our clinic are PRV regions to promote dose gradients around the abdominal OARs. So there's some uncertainty in where the colon or small bowel is going to fall from day to day. So you may want to employ a PRV, even an asymmetric PRV to use for treatment planning. And here's just an example of one for colon. And same thing with pancreas. So you may need to have a little bit of a margin around your bowel structures and abdominal OARs. And then even for treatment planning, to create somewhat of a modified PTV where you're pulling the PTV region away from the OAR since you know that they're maybe not the top priority. But you do have to be careful because you don't want to give no dose to that area. You may want to ensure that you're at least giving the tolerance dose to that structure in your plan. For treatment planning, Winston did a great job talking about 3D planning for SBRT. I'm going to talk a little bit more about VMAT and IMRT techniques. We employ those a lot for abdominal SBRT and pancreas, especially because of the surrounding OARs. We typically use partial arcs and avoidant sectors when it's reasonable. We try to avoid single arcs when we set up our VMAT plans, except for very simple geometries. And it's really important to practice smart ISO placement to make sure you have clearance for cone beam CT and for the machine for treatment. This is just an example of a partial arc VMAT plan from the patient that we've been using as an example. You can look at, again, the conformity and gradient indices for these patients, but keep in mind that you may make some sacrifices in your gradient indices compared to something like brain SRS for abdominal treatments because we are trying to steer dose away from these important abdominal structures. And so it's a little bit more acceptable to have kind of a skewed dose distribution, especially when you look at the 50% isodose line. And so here's just an example of that along that colon PRV where we're stretching out that 50% isodose line, and it's not exactly symmetric like you may see on other SBRT plans. Other tips and tricks, IMRT can be very helpful if you're treating, say, multiple targets close together, if the target's really close or overlapping a critical OAR, or when the target shape is irregular. If you are using an arc-based technique with a breath hold, be sure to minimize the use of avoidant sectors in your VMAT planning because it can cause the patient to hold their breath when you're not treating because the therapist can't necessarily tell when that beam's going to turn back on, so it's better just to have no motion at that point in the delivery. And non-coplanar arcs and beams can be really advantageous to the overall dose distribution. So I know single arc, one arc really fast is popular, but take into consideration that a non-coplanar arc could really help your dose distribution and help you get off some of those abdominal OARs. And the increase in delivery time for an SBRT patient's really not that much. A lot of our time is actually spent setting up the patient and reviewing the IGRT for these cases. Just a little thought about inverse planning. So many SBRT plans are actually very simple. We choose to use VMAT on them because it's a little bit faster for the delivery. But setting up the cost function maybe is not as simple as you think it would be. So this is just an example of taking a very simple 3D conformal plan where we have set limits. We've used a 0 block margin, as Winston talked about in his talk, and put say 11 to 13 beams all around the patient. And then we did the same thing over here. We have a partial arc VMAT plan, used a very simple setup. So just put dose limits on the target and then also used a normal tissue objective to minimize dose to the normal tissues with a very simple cost function. And when you do that, you can run into potentially unexpected results. And so this is just showing these two plans. So here in the triangle is the 3D plan, and here in the square is the VMAT plan. And what you'll see is that the default type of VMAT plan has a lower PTV dose and a higher liver dose and way more monitor units. And so you just have to be very careful when setting up an initial inverse planning program for SBRT in that you're really trying to make an SBRT-like dose distribution. And inverse planning is not necessarily going to give you an SBRT-like dose distribution if you don't ask for it. And so you want to set up your cost function to try to cause a hot spot in your tumor and also to really push down your normal tissues. So ask for a target hotspot. Don't push too hard on the normal tissue objective because it could end up with a lot of monitor units. And explicitly ask for minimization of OARs that you care about, like normal liver and abdominal structures. And be mindful of your complexity because you can run up the monitor units quite a lot. This is just an example from Joe Herman for a pancreas SBRT case. Again, you can see that they have very tight dose gradients around the abdominal structures. And one thing to keep in mind for pancreas, we're very surrounded by the abdominal OARs, and so you may not see the normal, really great coverage that you're used to seeing in an IMRT plan. You will have to make some sacrifices for these abdominal structures. And it's always useful to have really good plan evaluation tools. So this is an example of a tool that they have in their planning system where it's kind of like a scorecard for all of the many dose objectives that they have. And so tools like this are really helpful for evaluating SBRT, IMRT plans. So moving on to IGRT, I think one important thing to keep in mind is that standardization of workflow can really help reduce mistakes in IGRT. And pairing the proper image of the day with a proper reference image is really, really important. One thing that you want to try to avoid when at all possible is free breathing scans for IGRT alignment. So hopefully if you're using motion management, you are planning off of, say, an average scan from 40 CT, or you're planning off a breath hold scan. Any scan that you take that's just free breathing with an unspecified breath hold on the machine should really not be used for IGRT, and this is just an example showing using the average intensity projection as the reference IGRT. You keep your PTB coverage up well above 95%, but switching over to a free breathing scan, it could be all over the map. Some thoughts on planar versus volumetric IGRT. Aligning an abdominal patient with implanted markers is really easy. It's really easy for the therapist, it's easy for the physician to review. It really doesn't leave a lot of interpretation for target alignment because you have the markers, you have them drawn in, they're pretty easy to put together. Unless you have a big difference between different markers, it's pretty easy to do. However, volumetric imaging is pretty easy to align markers as well, and it also gives you the addition of soft tissue visualization of your organs at risk. And so this is an example from our clinic looking at an abdominal liver case. Here you can see the gallbladder and the colon, and first day of cone beam, you can see that the gallbladder has changed shape dramatically and our colons move directly into the high dose region. And this is something that if you were aligning with a marker in the tumor, you're really not going to appreciate. Optical tracking is something that can be used for any SBRT site. It can reduce imaging dose, eliminate multiple imaging and repositioning, and it's really nice for intrafraction monitoring because you can identify gross errors and motion during the treatment. So it's, I think, a great complement to traditional imaging-based alignment, probably not ready to be used independently. Sam's question, so which of the following should be avoided in IGRT of free breathing abdominal SBRT patients? Cone beam for IGRT, fiducials for IGRT, average intensity projection CT for your IGRT reference image, a free breathing CT for the IGRT reference image, or use of optical tracking for intrafraction monitoring. Okay, great. No free breathing CT for IGRT. And there's the reference. Okay, one more question. So which of the following does not contribute to reduced potential toxicity in liver SBRT? Breath hold treatment, use of planning risk volumes for abdominal OARs, minimizing mean dose to the liver, free breathing treatment, or cone beam CT based IGRT? This must have been a really easy one. Okay. Oh, sorry. Okay. Oh, all right. All right. Excellent job. So of course, free breathing treatment will increase the amount of normal tissue irradiated, while the other answers would minimize risk to normal tissue. Okay, so now I'm going to hand it back over to Mary to talk about the clinical aspects of prostate cancer.
Great. Last little module here. So prostate cancer SBRT. Why SBRT for prostate cancer? Well, as you've heard, it's a common theme. It's more convenient. It's 5 versus sometimes 43 treatments or more. So far more convenient for patients. Less costly as well, usually on the order of $20K versus $30K, so less cost to the patient, less cost to society as well. Theoretically, it might be more effective due to high doses per fraction and the low alpha beta for prostate cancer that's been theorized. It may induce a helpful immunologic response, maybe for prostate cancer, maybe for other cancers as well. And what we found recently is that there's a very similar patient-reported quality of life as well, which has been a concern for some people in employing prostate cancer SBRT. So is prostate SBRT ready for prime time? There are now a couple of thousand of patients with a couple of years follow-up. This is a little bit of an old slide, but you can see that the biochemical control is actually quite good, and late grade 3 GI toxicity and GIU toxicity are very, very, very low as well, so very promising. The hottest data is on quality of life, though, and in this recent paper looking at a large multi-institutional database of fractionated radiation, brachytherapy, and SBRT, recently they were able to compare different quality of life metrics, so urinary irritation, bowel, these are patients on hormone, these are patients with urinary incontinence, sexual function, that sort of thing. And you can see that looking at the 3 different modalities, many of them are pretty much very close together. And with SBRT, which is the dark gray, sometimes it falls out a little bit better in some of the different metrics. But overall, it's pretty much right on par for all the different therapies. There was a concern with higher doses per fraction in the normal tissues nearby, especially the rectum, that quality of life might actually be worse for SBRT. So this is this is reassuring. So first, Sam's question for prostate, patient-reported quality of life. Quality of life after prostate SBRT is, I have liver on the mind, much better than brachytherapy, much better than conventional fractionation, much worse than brachytherapy, much worse than conventional fractionation, or about the same as brachytherapy and conventional fractionation. That was mine. Aha, excellent. About the same. There are some measures that seem to be potentially a little bit better, but there are fewer patients treated with SBRT so far, so the jury's still out a little bit, but very reassuring and promising. So who would be a good candidate for SBRT for prostate cancer? Since it's more convenient, it seems to potentially have the same outcomes. In multiple studies so far, it's really been confined to patients with a Gleason score 7 or less, so patients with what's called low-risk prostate cancer or kind of a low-intermediate risk prostate cancer. Low PSA score as well, meaning that the cancer probably hasn't spread to the seminal vesicles or the lymph nodes, because those would be very challenging to treat with SBRT. Tumor confined to the prostate, so hasn't gone out of the capsule into the area close to the rectum, for example. In patients who have a small prostate, that allows for better dose fall off, and patients with good urinary function as well. For patient positioning and simulation, it's very important to do a pre-simulation prep, just as patients have done for fractionated therapy as well, but even more important for SBRT because it's fewer fractions, you have less room for error. Typically we have fiducials placed in the prostate, whether they're just standard markers or tracking markers. The empty rectum is very important because we want to have a very consistent prostate position and a prostate position relative to the rectum as well, a full bladder to get the bowel out of the way. For CT simulation, we typically simulate patients supine, although if we're going to do RF tracking and their body habitus is a little bit large, sometimes we have to flip them supine in order to read them on the tracker. Arms up, legs straight, or knees fixed, toes banded. We have thin cuts through the prostate, so we can delineate that better, and otherwise 3 millimeters in every other axial slice. And it's really important for prostate SBRT to define the urethra. That's not something you can see on a non-contrast CT scan typically, and that needs to be marked out either with placement of a Foley catheter, an injection of some radiopeg contrast, or a catheter that is visible on a CT scan, or using an MRI registration to fuse that to really see the urethra, because again, it's really invisible on a regular CT scan, and we don't want to put high dose in the urethra because it causes a lot of toxicity. So prostate simulation directive, again, we like to template these things, and the important issues I want to talk about are pre-simulation, full bladder, empty rectum, very important. Our therapists check that, so if they don't have a full bladder or they don't have an empty rectum, we send them to go off and remedy that situation before we actually scan them again. Patient immobilization, typically supine, but we sometimes have to flip them over prone if there's too big of a distance between markers that need to be tracked and the patient's surface. And the scan parameter is really important so the patients are scanned adequately. Let's see. So what needs to be contoured for prostate? This is pretty easy. It's all the same things that need to be contoured for fractionated prostate radiation except for the urethra. So you can see on these, if you don't do SBRT, you might not have ever seen a urethra contour before, but it pretty much goes midline if you're looking at the coronal, but it takes a turn, and it takes a very highly variable turn from patient to patient, connecting the bladder to the outside world. And it could be much more crooked or it could be straighter. And so that's why it's really important to know exactly where it is for each patient to know what you're going to be sparing. And then the penile bulb below here as well is important, we think, for sexual function. So margins, similar side to everything. CTV equals the prostate actually for prostate cancer because there are usually multiple prostate cancers hiding within one person's prostate. So even though for research purposes sometimes people do whole prostate plus maybe a boost to a nodule, the whole prostate is still typically part of the target. And then the additional margins again just depend on any other decision that you've already made. So it's very important to have a really integrated system from start to finish. So here's some results from a multi-institutional study of SBRT for prostate, and this was using the Calypso tracking system for very, very small margins, and this was done by the University of Michigan in collaboration with a bunch of other centers across the country. These are the target and normal tissue dose limits and goals that we had set up. So the prostate PTV, we were shooting for 37 gray in 5 fractions, and there are other additional limits as well. And there are multiple different limits on the rectum with different percent volumes and different absolute doses as well. The prostatic urethra, as we talked about, which is contoured again either through the Foley placement or the MRI, is very important to make sure that the doses, there's no hot spot in that area. Bladder, penile bulb, femoral heads, and then of course the skin were considered as well. So the phase 2 trial is closed. It hasn't been officially reported yet, but we had all 66 patients were enrolled and treated as of 2 years ago, so it should be coming out hopefully soon. Minimum follow-up was 14 months, and there are no biochemical failures. So everybody is controlled so far, which is very reassuring, and no grade 3 acute or late toxicity in any of these patients, I think, because there are very, very strict limits on the urethra, rectum, bladder, everything, really biasing the treatment planning towards avoiding OARs rather than getting the best, highest PTV coverage possible. So here are these guidelines again. This is for prostate cancer from the NCCN, and the language is different here. So instead of just clinical trial, yada, 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 like in for pancreas cancer, this actually says they can be considered as a cautious alternative to conventionally fractionated regimens at clinics with appropriate technology, physics, and clinical expertise. So Martha's going to tell you all about the appropriate technology and physics expertise necessary to do this safely.
Sorry, with the tag team approach, it's hard to know if you should clap or not. Okay, so there was this really great review paper that was in the Red Journal last year that reviewed a bunch of recent prostate SBRT literature. And so I really just wanted to give you the summary from that paper, which I thought did a really nice job summarizing what's available right now. So they looked at a survey of different aspects of treatment, so delivery modalities, positioning, margins, use of markers, and use of IGRT for prostate SBRT trials in the literature. And things were all over the place. So delivery modality, what sites are doing, it's a combination of Linac, CyberKnife, tomotherapy, 6 to 15 MV photons only. There were no proton studies here. And most sites were doing IMRT. I think there was 1 or 2 using 3D planning. And I think that is pretty typical when we consider most sites, I think, are also using IMRT or VMAT for conventional prostate radiation therapy as well. As Mary mentioned, most people are going to do supine positioning. It's a little more reproducible, but many sites do need to use prone positioning. If you have a larger patient and you're using RF tracking, there are some limits to where you can actually track those patients. So we have in Michigan quite a few patients that are treated prone if we're doing RF tracking. There was a huge range of margins used on the PTV, 0 to 5 millimeters. This is something that I think we have to be very careful about. Many of you may have seen the paper a few years ago looking at the reduced local control and outcomes for prostate cancer using IGRT in small margins. So you just have to be careful. You want to make sure that your margins are appropriate with your IGRT, and I think each clinic kind of has to evaluate that on their own with their own technology. Every study that they surveyed in this paper used markers. So markers were kind of a big theme behind prostate studies in general, and definitely for prostate SBRT, either gold seeds or RF beacons. And then IGRT was a combination of KV, MV, cone beam CT, and tracking. So I put motion management here in quotes. So of course we're going to see very minimal, if any, breathing motion that you'll see in the prostate. However, there are a lot of other types of motion that you see. So you can see a significant motion or changes over a pretty short time period with prostate patients due to rectal and bladder filling and changes. And so I think that's one of the reasons that RF tracking is very popular for these types of patients, because you are getting real-time information on those changes, especially as we're treating to smaller and smaller margins. This is really important to get kind of real-time information if you're trying to treat with, say, a 1 or 2 millimeter margin. Good news on treatment planning for prostate SBRT. It's actually very similar to treatment planning for conventionally fractionated prostate IMRT and VMAT planning. You're not necessarily trying to create that same SBRT-like dose distribution that you want to get in, say, a lung or liver SBRT. You want to get a nice homogeneous dose, and you really want to actually avoid those hot spots in the center of the PTV, because that's where the urethra is. So there are slightly stricter objectives, so it may be a little bit harder to meet your goals. You do need to employ urethra sparing, so that's something your dosimetrist will have to learn. And if you have smaller margins, it may actually make sparing the bladder and rectum a little bit easier, but that goes along with having a little bit tighter dose limits on those structures. This is just an example from our clinic of one of our SBRT prostate patients and kind of the prep that the dosimetrist goes through to set these up. So here again, you'll see, whoops, that the dosimetrist has registered the scan where they had the Foley in, and so here's the urethra in green. As Mary said, this can change depending on the patient. It's a little bit hard to see, but this purple is the PTV, and then in red, the dosimetrist has created kind of a treatment planning PTV. So here he's excluded the rectum and actually made a 1 millimeter margin around the PTV to really ensure good coverage right at the edge. So that's something that your inverse planning system may struggle with. And here he has put in margins around the normal tissue with a little bit of a gap. These are kind of what we call rings or normal tissue annuli that we use for treatment planning. And we tend to use these instead of the normal tissue objective in our treatment planning system. And some of this is dosimetrist preference, and some of it is just the ability to really control the hot spots right around the PTV, because you really want to avoid having hot spots kind of peeking out around your PTV when we have such large doses. And so this is an example of a prostate SBRT IMRT. We actually use the same 7-field arrangement that we use for our conventionally fractionated prostate patients. I wouldn't recommend probably going down to 5 beams, but 7 to 9 equally spaced beams is probably a good choice. And here you can see this is the prescription dose of 37 gray, really well contained in the PTV, but not going into the rectum. So this does take some tweaking of your cost function here and there, but you can get a very nice dose distribution with these patients. Here you can see the fall off at the rectum and no hot spot here in the urethra. And same thing if you were to treat the patient prone, it's pretty much the same story. You just flip the patient and you can get a similar dose distribution. Had to put in a picture of plan that we retired a couple years ago. One thing to keep in mind with these patients is rotations. So with changes in rectal filling, hopefully you're giving the patients rectal instructions for bladder and rectal filling instructions to try to keep that consistent, but there are going to be changes from day to day, and depending on the shape of the patient's PTV, rotations may be really important or they may not be that important. If you have a very spherical target, maybe it won't make such a big difference, but on a patient where the PTV is a little more oblong or different shaped, different rotations can have a really big impact on dose to the rectum and coverage to the target. So you may need to calculate that out and figure out what your limits should be for tracking for rotations. IGRT is really important, especially as margins are reduced in this site. And so this is just showing a study where they had 0 millimeter margins, and they looked at what type of corrections they're doing or required to do for their IGRT. So purple is no corrections, red is translation only, translation plus rotation 5 degrees, translation plus rotation 10 degrees, or full corrections with translations plus rotations. And you'll see there's a lot of sites where you need translation and rotation up to 10 degrees with no margin. I don't advocate no margin. Here's 3 millimeter margins, and again you'll see that you need to apply translations and rotations potentially to really keep your CTV coverage above 95-99%. One of the benefits of real-time monitoring for prostate, SBRT, or conventional is that you see a lot of different types of motion for prostate patients. So this is an example from that paper that I mentioned before with periodic large motion, and then the patient settles in. The therapist didn't need to move the couch at all, but they're tracking the patient. When the patient moves, then the beam is held off, and so you can see the beam interruptions here during large areas of motion. And then there's other types of motion where there's a slow drift and then a correction even before treatment starts. So you see a big range of different types of motion with prostate patients. Looking at planar X-ray and cone beam CT for prostate localization compared to something like real-time RF tracking, not big differences. So this is the difference between KV imaging and Calypso and cone beam CT and Calypso. Really small differences in general. I think each one of these techniques can be used successfully for prostate localization. But the one nice thing about having volumetric imaging is you catch things like changes in rectal volume noted on cone beam CT that you're not going to see as much if you're just doing real-time tracking with no imaging. And this was a really good example of that. So If you just have markers and that's all you're tracking, here you can see a marker or a calcification potentially in this patient. Looks like they're about in the same position. These are 2 cone beams taken 6 minutes apart. And you can see a huge change in the prostate, rectum, and bladder over a really small period of time. And so this is something that hopefully you would see with real-time tracking, but we can't catch everything, so you do want to be careful. Okay, Sam's question. So which of the following is not true regarding SBRT for prostate cancer? High-dose per fraction may be more effective for prostate cancer than fractionated. SBRT requires fewer treatment planning and physics resources than fractionated IMRT. High-dose per fraction may induce helpful immunologic responses. SBRT is more convenient for patients than fractionated, or SBRT is less costly than fractionated. Sorry, those were kind of long answers. Okay, correct. So, of course, SBRT doesn't require fewer, it's just as many, if not more, when you're doing SBRT. And so in summary, for, I guess, both of the talks, we think there's mounting clinical evidence supporting the use of SBRT for liver, pancreas, and prostate. And the safe and effective initiation and growth of a program in these sites requires looking at your whole process, from decision making from the physician side, from tumor board, simulation, treatment planning, and IGRT. On the physics side, we know that we have to take into account motion for abdominal SBRT. There are lots of different ways to do this, but you want to make sure you have your system properly commissioned and your staff trained. You want to avoid toxicities and maximize your ability to control the tumor. You want to follow strict treatment planning priorities, and we really need to get more data on abdominal OAR toxicities because that's one of our limiting factors in dose escalation. IGRT is really important, and you want to make sure you're pairing up the right image of the day with the right reference image. And prostate SBRT planning, of course, we think shares many similarities with current fractionated techniques, in that margin reduction can be done safely, but only with really good IGRT and simulation and mobilization techniques. So thank you to the organizing committee for inviting us to speak today, and also wanted to thank our U of M SBRT team. There were way too many people to list. You know, our whole team, from the physicians, dosimetry, physics, therapists, and we have a new safety officer as well. And I've listed Mary and my emails if anyone has any further questions. Thank you.